So to begin, I will just give a brief introduction. My name is Haley, and I'm currently serving as the Student Experience Officer on the Europub Health Students and Alumni Association board. And I'm also a current EPH Plus student, having completed my first year in Dublin and now specializing in the leadership and governance track at Maastricht. So before I hand things over, I'm just going to run through a few housekeeping items. This session is being recorded, as I said, and it will be uploaded to our channels following its completion. We will also be taking attendance, as those who attend at least 3 out of the 5 talks this academic year will be able to receive a certificate. So please make sure to fill out the Google form that we will circulate in the chat multiple times throughout the evening, just so that people are able to access it if they come a little bit later. So as well, the session will be about an hour long with some time for questions at the end. If you do have any questions, please feel free to put them in the chat or raise your hand when we get to the Q&A portion of the evening, which will be at the end following all of the presentations. So to begin, I'm going to start with introducing our moderator for today's talk. We have Brenna Stanton with us, who is a current EPH student, also currently in Maastricht. And Brenna has previously served as the community outreach specialist, in which she worked on developing a digital literacy program in which volunteers would teach older adults about technology. And we are happy to have you with us today, Brenna, so I'll pass it over to you.
Thanks, Haley. Hey everyone, I'm moderating today's talk, and as Haley mentioned, I will be collecting questions both through the chat and the raise hand function, and leading the Q&A portion of our talk today. One note about the Q&A, if you could please direct your question at which of our 3 presenters you would like the question to be asked. So that goes for if you write it in the chat or if you raise your hand. Today, as I said, we have 3 speakers. We'll first start by introducing our first speaker of the day. Dr. Vianney Jouhet is a French physician specializing in public health and medical informatics. He works at Bordeaux University Hospital, leading projects on health data and digital innovation. Dr. Jouhet's work focuses on using healthcare data responsibly to improve research, public health, and the quality of care. With a background in both medicine and computer science, he also collaborates with national expert groups and the Health Data Hub on data governance and health informatics systems. With that, I'll now hand it over. Dr. Jouhet.
Well, hi, everyone. Can you see it? It's okay? Okay, perfect. So thanks a lot to give me the opportunity to speak today. I'm happy to talk about this presentation, which is entitled From Data to Decision, and also to fit with the session, I added a subtitle, Smart Use of Health Data Information from Stronger Communities. So I'll be speaking a lot about that data and being able to reuse them, because as you may all know, for now we have a lot of data that are available, collected all along patient care and also research data and social networks data. And on the other side, there's more and more computation capabilities and also a lot of methods that enable to process data at a large scale. So there is a growing interest. It's not recently, from a few years ago, in reusing the data, and especially the data that are collected during patient care. And this is why we are talking here about secondary use of health data, which is a topic which is really interesting. And reusing the data leads to the idea of real-world data. And by real-world data, in fact, we means all the data that are collected during patient care, by opposition to research data. And today, I'll be specifically talking about data that are collected in the hospitals, because this is the topic I work on. But there are also a lot of dimensions that are really important and need to be collected and being available for secondary use. And from real-world data, the main goal is to produce real-world evidence which also correspond to evidence that you could build upon data that are collected during routine care. This doesn't mean that data and evidence that are collected specifically for research is not something good, but the idea here is that maybe we could do more stuff with the data we already have. Something important for digital public health is that this real-world data and the ability to reuse them is a kind of promise. And what you have to keep in mind is that this is still a promise. There are some results in this topic, but there is still a lot of work to be done. I know that a lot of people are saying that it is the future, but yet it is still the future for now. It's not for today. The advantage of this kind of data is that they are timely, collected all along patient care, and you have the data as soon as the data has been collected. They can be massive, which is very important. They can also make available data for large population and more representative population. And it could help to do some kind of digital transformation for public health. For instance, I'll show you example real-time health surveillance or early detection of outbreaks, which is, as you may know, is something important because we have had COVID-19 and we know now that it is really important, but also some kind of predictive analytics or even trying to predict individual outcomes for patients. So this is a topic that is really important. And the idea here is to be able to move from these data that are real-world data to real-world decisions so that people or decision maker or practitioners can make good decisions based on this data. So there is a lot of stuff to be done to be able to do that. And the first thing that you should know is that when you try to reuse hospital data, you face a big challenge, which is named hospital data silos. So you just have to imagine that within a single hospital, there is not only one application that will enable to collect the data. In fact, there is multiple applications and each applications will have its own database and the database is complex. So just to give you an example, in Bordeaux University Hospital, there is more than 100 applications and it corresponds to a lot of tables within different databases. It's extremely heterogeneous. And if you try to query this data all together for research, you will face two main issues. The first one is the query complexity. It will be really complex to query the data. And also the second one is the execution time. It could, if you are not working on it, you could just send a script and try to query the data and wait for 12 hours or 20 hours to have an answer. And this is not possible to have this kind of execution time if you want to put researcher in front of the data because they don't have time to wait for 12 hours to have a result. So they want something much more efficient. In order to tackle this issue, we use something that is called a clinical data warehouse. So it's a data warehouse, but which is specific for clinical data. This is the idea. And this is something pretty easy to understand. On the left side of this slide, you have all the databases that are heterogeneous. And the idea here is just to extract, transform, and load the data into a system that will be more optimized for query processing and also that will group the data all together so that it will be really easier to reuse the data. And then from the clinical data warehouse, you have to be able to implement multiple use cases that could be data visualization, building strategy for the hospital, or studies, research, or even clinical or epidemiological surveillance. So it's pretty simple in the idea, but just I think you could imagine that here the part which is extract, transform, and load introduce some kind of complexity. And at this point, if you want to do research with the data, one thing that is really important is to avoid black boxes. So you have to be transparent on what you are doing because you want your researcher at the end of the day to be able to understand the data they are using and where they come from. So just to give you an example and something positive, when you implement this kind of clinical data warehouse within a hospital, you are pretty happy because you can collect data from 4 million patients, and you have like 3 billion observations, which means 3 billion data points. So there is a lot of data available. And I could say this is perfect. People could use it then, and they can do a lot of work. And this is often the case because clinical data warehouse all around the world enable to reuse the data from hospitals. But if we look at it more deeper, there still is an issue that is important. It's the fact that even if we have massive data within these clinical data warehouses, when you go to a specific topic, for instance, here it's adenocarcinoma of lung with specific mutations and with specific treatments, you can go from 16,000 patients that you could be included. But if you apply all the inclusion and exclusion criteria, you will go just to 100 of patients, which is certainly not enough for the study that the researcher want to implement, which means that in fact, even if you have collected a lot of data within a single hospital, you need to be able to share the data with other institutions to implement the real world use cases and to produce real world evidence. So just building a clinical data warehouse inside an hospital is not enough. So what I want to introduce here is that more than building clinical data warehouse for single institutions, we need to share the data. But we have another issue that is a really important one, is that health data are sensitive data. So when you collect them and when you want to reuse them, it is regulated by the GDPR in Europe. And this is a good thing for us because it protects us. I mean, this is an issue, but the data are really sensitive. So we have to be careful on what we are doing with this data and what risk of re-identification of patients, for instance, or what risk for data leaks we are implementing. And here the GDPR implies one principle which is really important, which is the principle of minimization. And behind minimization, there are multiple stuff. The data has to be pseudonymized. We don't say anonymized because we have so much detail about the patient that even if you remove the identity and the identifiers of the patient, you can re-identify them indirectly. If you have information about the person, then you can deduce from the data who it is. You could, if you want to try, or if you have information. So the data still remains sensitive even if we remove the identifier. We also have to implement transparency, which means that at any time, any people that is concerned about the secondary use of data should be able to inform himself about what we are doing about the data. We have to say which data has been used for which use case. And also, we have to implement the GDPR. So if people want to opt out, they need to be able to opt out. We need to remove the data and don't use them for later. And also something important, which is the main issue there, is that only anonymized data can be shared easily. And as I said to you, if you have individual information with a lot of information for each patient, then it is not considered as anonymized. So in theory, there is no way to extract the data from a clinical data warehouse and share it with another institution to implement a multi-institutional data warehouse. So it doesn't mean that it's not possible, but you will face the issue of asking for authorization, and you will have to wait for months and months and months. Another issue that is really important is the necessity for trustworthy data governance. This is really important, and this is even more important if you want to use data a bit far from the people that produce them. Just remember that around the data, there are multiple actors that have multiple roles, and every of these actors thinks they are proprietary of the data, which is not the case, in fact, because the data is just like organs of person. There is no way of selling them. You cannot pay for transfer of data, so there is no ownership for data in health. This is also something that is really good because it protects us from some kind of merchandising our health data, which are sensitive. Just you could imagine that the healthcare professionals that are collecting the data thinks they are the owner of the data, which is not the case. And also the patient has rights regarding this data, but it doesn't own the data. So the data are something that should be shared, but people want to keep them for themselves. So you have to convince people that the data has to be shared for secondary use. And for that, you need to build a trustworthy data governance. So just to introduce to you something that is really important and work that is ongoing around these two issues, which is about being able to share data or implement multi-site, multi-institution studies across multiple clinical data warehouse. The approach that is implemented, it's called federated networks. And the idea behind federated networks is that you will just keep the data localized in each institution. You don't move the individual data, you never share them, but then everyone will standardize his data in the same way. And then you will send a script to the network. So you will send programs that will be executed on top of this standardized data. You will produce aggregated results, and then you can share this aggregated data, which is only number of patients having something or betas of a logistic model or stuff like that, which are fully anonymized. So you can share them, and then you can implement multi-institutional studies across multiple institutions. And this is a really good idea because it enables to build big networks across the world, and it's pretty acceptable for the institution, the actors, and also from the GDPR perspective. Just to show you 3 examples, the first one is a consortium that was built very fastly during the COVID pandemics, it was able to federate 300 hospitals worldwide. And from the first idea to the first result, there was only 1 month. So all these hospitals were able to share information, aggregated information, and to produce insights for COVID-19 at the beginning of the pandemics. And it was a really efficient way to implement this. So this is, I would say, a specific example because the context was a bit different. It was COVID-19. Everyone was at home, so everyone wanted to do something to help. So it was easy to have that much hospitals available and working on it because people were working full-time on COVID-19. But then this consortium has produced a lot of papers and a lot of publication around describing how COVID-19 was evolving during hospitals and how it was different between countries. And there are a lot of papers that were produced during the months that followed this first publication. Another example, which is more at the European level, it's something that is established by the EMA. So it's the European Medicine Agency, which main goal is to implement the surveillance of medications and identify adverse events, for instance. And EMA has built a network which is called Darwin EU, which federates 30 data partners with a lot of data sources, and it covers 200 million of patients, and it has already implemented 100 studies. It's an ongoing network that was built 4 years ago. And something important here to say to you, it is based on the specific data model, which is called OMOP CDM for OMOP Common Data Model. There is one issue that has to be addressed for each data partners is to be able to build standardized data, which means standardizing both the syntax and the semantics of the data. And the semantic part, it's something that is pretty complex because you have to map any information you have in your clinical data warehouse to some kind of standardized terminologies, which could be a long and hard work to be done. Within this network, only aggregated data are shared, and the analyses are built methodologically upon meta-analysis methods. And my last example is a French project, which is called Orchidée, which is a EU grant and which federates 25 university hospitals in France. And the main goal is to produce timely, reactive, hospital-based automated indicators for public health surveillance. And the first use case that is implemented, the project has started 1 year ago. And the first use case is building severe acute respiratory infection indicators, which is something really important because of the COVID-19. There's also the flu that is coming every year. So we have to build a timely and reactive surveillance to be able to follow what's happening at the national level. And it's also important at the European level. In this federated network, we do exactly the same. We have some clinical data warehouse in our 25 institutions. From this clinical data warehouse, people are building standardized data marts that will have all the same structures, and then they will run specific scripts that will produce standardized indicators. And what is really cool about this network is because of the standardization process, we ensure that everything that is produced exactly the same way for each hospitals, which aims to produce evidence for decision makers in case of crisis among the SARI use case. Here it is just an example of the kind of indicators that could be produced. It's just from Bordeaux University Hospitals, but there are also other hospitals that are producing, but painfully, I cannot show the results yet because it's too early for the project and we are just consolidating. And here you can see that we can follow using different data, how the flu is going on every year. And we have some early pretty interesting results, and we hope that we could implement this for September of the next season. That would be really cool for the nationwide system surveillance. So just to conclude, federated network, it's can exhibit some kind of limitation depending of the study objective. If you need to know that people came across different institutions, you won't be able to do that, of course. If you need to aggregate individual data, you won't be able to do that. However, it's a really important example of smart use of health information for communities, because it builds confidence between the actors, because the data are kept by each institution. People are sure of what you are doing of the data. And also you can communicate with citizens locally and inform on what you are doing, even if it's within a network. You can communicate with health professionals locally. And everything that is implemented rely on the local knowledge about health data, which is something really important to avoid black boxes. It's also comply with the GDPR and prevent individual data leaks. At least it tries to prevent them, but it's way better than putting all the data together. And it can provide a lot of insight for public health decision making. For instance, Orchidée and Darwin EU are providing information from decision makers already. The Darwin EU for the medication surveillance, and Orchidée will produce them from next year to help decision making in case of crisis from like COVID-19 or other use cases. And also, it can benefit to the population at multiple levels, local, because we are producing data that can provide evidence at the local level, but also national, using data in national networks, and even for the European population, if you are building indicator to be able to assess adverse events from medications. So I thank you for your attention, and just to remind you that this kind of work can only be done with a lot of people that are really implicated in building this kind of federated network.
Thank you so much, Dr. Jouhet. I'll move on to our next speaker then. Our next speaker is Mariam Shokralla, a healthcare professional and digital health strategist. She's currently based in the Netherlands, and she's working with the Healthcare Information and Management System Society for the EMEA region. Trained as a pharmacist, Mariam also is an EPH alumni. She went to Sheffield and Maastricht from the 2019 cohort. She brings over a decade of experience in medical device regulation and digital health policy, having advised the WHO and national health authorities across Europe. In her current role at HIMSS, she leads projects on health data, artificial intelligence, and digital transformation, helping advance interoperability and governance within the European health data space. Thanks so much for joining us, Mariam. Take it away.
Sure. Thank you so much, Brenna. It's really such a pleasure to be with you today. I am everything that I am doing now in my day-to-day work is impacted by the fact that I am an alumni of this amazing program. So I can't be grateful enough for this program. I think Vianney already have done a wonderful job to sketch or to give you a much more detailed use cases on how we use data in real world. I'm going to step back a bit from that point and give you a little bit more abstract kind of concept about data and about what public health actually, how public health and digital transformation is actually intersecting, and where AI as well fit into this whole thingy. I will try to be very short, but let me start with my introduction, because I'm a pharmacist and I have been working in medical device regulations for quite some time before I came to the program. I did Sheffield as a normal Olympiad, and then I came to Maastricht, and I was actually the first cohort that come to Maastricht for European health policy, because I really was so fascinated about how Europe or the EU is trying to influence the policy across different member states. And I really had a wonderful time in Maastricht. This is why I stayed behind till now. I was in the cohort 2017-18, so I have been here already for quite some time. As Brenna said, I work as digital health strategist, and it starts from the fact that I wrote my master's thesis at that time on the digital transformation of healthcare and how it impacts inequalities. That was literally before COVID. So I graduated literally before COVID, like July 2019. And then in November or in December, COVID hit. So suddenly everybody was talking about the topic that I was writing my thesis about, which is what is digital public health and how the digital transformation of our healthcare systems, secondary or primary care, is going to impact equality in a different way. And we, at that point, we have not thought a lot about it from a public health perspective, but this is why I wanted to dive deep into this in my master's thesis, and then that launched my career into doing more digital health now. So on my, just to give you an understanding on what I do on a day-to-day basis with HIMSS, I act as digital health strategist, which means that HIMSS own a suite of products called maturity models. So these are kind of consultancy products where they could be used by hospitals to gauge and to measure where they are in their digital transformation. As you probably know, healthcare is a little bit coming very late to what digital transformation can provide. A lot of other sectors has been already digitized by the time that we started talking about it. And of course, COVID was basically the biggest the biggest contributor to this whole conversation about digital health. I think before COVID, digital health or digital transformation of healthcare was really more of the informatics people or people that already work in healthcare institutions, but there was less about how public health specialists can actually work or how the digital transformation as well of the health systems in general is going to impact what we do on a day-to-day basis as a public health specialist. So this is what I want to focus a little bit with you. So the whole digital transformation of healthcare aim to arrive at those 3 points. Data-driven ecosystems, so to allow our health system to be much more intelligent. This means that from the time that you step into a hospital, your record, your diagnosis, your allergies, and so forth are documented in structured formats in electronic health records. So this is one of the tools which Vianney works with a lot in hospitals. Again, I'm really going back to basics because I know not everybody here is actually a medic or have worked in a hospital institution or something. We also know that with AI evolution, we gained a lot of analytics capability, as also Vianney have said, so that put an onus on us to think about, okay, the amount of data that we have in our health systems that now has been digitized, how we gonna extract value out of it. And that's actually where a lot of hospitals at the moment is still kind of stuck, because everything in a lot of hospitals, at least in Europe, is a little bit digitized. So you go to a hospital, you go to a GP, and then they capture your clinical information directly in structured format. But in the same time, nobody really knows what they are going to do with this data. But after COVID, we started to see a lot of use cases about how this data could be used for disease management. And then that put us into the question of, will public health stay as a population health science? So, or it's going to shift it to individual care. And the reason I am sending you this question so you can reflect on it a little bit, because when I am in hospitals evaluating electronic health records using these maturity models, we rarely come across any public health people who work actually in the hospitals, while a lot of hospitals are starting to say, okay, we wanted to use our data for population health management programs or for even personalized prevention. And when you look at personalized prevention, you could ask yourself, is that a healthcare credential? So is that the responsibility of the specific clinician that you see in your primary care visit or in the hospital? Or is that actually a specialty where public health professionals can actually help in? And at that point, you feel that there is a little bit of loss into where the personalized prevention, if we know a lot about you as a patient from the data that has been generated about you, either in the healthcare system or even if they are person-generated data, because you have a wearable, you have a Fitbit, you have a glucometer at home, and so forth. Where is the intersection? Who is responsible for individual prevention? Usually in public health, we say we're so good at population level prevention. So what are the interventions that's going to bring the most benefit to most of the people? But how can hospitals, when they look at individual prevention, utilize the public health specialist credentials or capacities and skills to actually look at population health management programs in hospitals? So for example, bringing all diabetic patients treated in one specific hospital, look at their epidemiology, look at all of their records from their electronic health record that has been captured on them, stratify them, who is completely managed, who's not, and so forth. Who's going to do that? Usually the hospitals doesn't necessarily have the capacity to do that. The hospital is pretty much mandated to kind of deliver an individual care. You go there as a patient, they take care of you as a patient, but they do not necessarily have this umbrella or mindset of thinking on a population level. And this is why I hope at the end of this, I convince you that public health specialists have a very important role and place in hospitals in talking with multidisciplinary teams, including informatics, software engineers, who actually work around the electronic health records in hospitals or in primary care as well. I already spoke a little bit, sorry, I already spoke a little bit about electronic health records this is the like software used in hospitals to document care. And now they have become one of the unconventional or untraditional sources for data for us as public health people to actually look at this data and see what we're going to do with it on a population level. If you go also a little bit abstract or much more on the EU level, Vianney already spoke about federated way of looking of analyzing data, in which instead of moving the data to the researchers will move the query to the data in a way. But on the policy scene on the EU, probably all of you have read, or maybe during your masters, about the EHDS, the European Health Data Space, which is basically the very first initiative on an EU level to actually mobilize data of the patients that has been generated, whether in the healthcare systems itself, so in hospitals or in GPs, or the data that generated by the patient themselves because they are using apps or wearables, how they mobilize this data. First of all, give the patient themselves access to this data. This has never been a situation before. We have never seen a lot of voices before to say, okay, give the patients their data because they want to understand themselves better. That is a little bit new. And this happens also because now we have a lot of tools, even as patients, and as patients becomes more partner in care, they want their access to their data. And this is what the European Health Data Space wants to do as well, which is what I captured here as EU-wide integration. So it has become not only sufficient for the patient to have access, or for you to have access to your hospital records or your primary care records, you also want to do that and mobilize this data as you move from one European state to another. Or for example, if you are a rare disease patient, you can be treated somewhere else. Now, the fact that care itself is documented digitally, and that is not the reality everywhere, because of course there are still hospitals even in Europe, and I'm not even talking about other parts of the world, that still document care in papers, or at least pieces of the care has been documented in papers. But there is a consensus that there is a certain level of maturity across most of the European hospitals, at least in Western countries, that they are already using electronic health records to document care. Therefore, there is an real-time structured data already exists in these systems. Now, the question is how we're going to use it, and not how we are going to use it to provide reactive care, so provide care on that episode. So I am diabetic, I go to the clinician, he can get access all of my, for example, HbA1c that has been previously generated in multiple hospitals before. Not only that, but how he also can proactively determine what's my, for example, rate of deteriorance. For example, if I am not my medication adherence is very low. So you move more to a proactive surveillance. Now, this is what the hospitals now are battling with these things, and how to use, for example, AI as well to predict the outcomes of individual patients. And then again, you can ask yourself, is that a public health skill, or is that more a clinical skill? So I am not trying to confuse you, but I'm trying to say that the whole digital transformation of healthcare, and the fact that we are documenting much more data in a structured format about patients, blur a little bit the line between where public health specialists perform their own credentials and skills and use their skills. Usually they would analyze registries and analyze specific data that they might have already generated as a primary data. But now they have to move a little bit to make sure that they can use the existing data in these electronic health records. And not only for research purpose or the secondary use, as Vianney have said, but for the actual primary use, which is taking care of populations, if that makes sense. So it became more and more important for public health professionals to actually understand what is secondary use of data, and that involve, of course, something like federated machine learning, that you already know what type of data has been generated about these patients in these electronic health records. And that will also, the amount of data that has been generated in the healthcare system made or emphasizes that data is the new commodity. Data is the new oil, if that makes sense. It's a very old saying, but data is the new oil that's going to impact or help us redesign our healthcare systems and allow our healthcare systems to be learning healthcare systems. And this is what we see a lot of countries are grappling with at the moment. So again, the digital transformation impact the public health professionals and public health as a discipline in so many different ways, including those 5 impact areas that I am mentioning here. It is going to impact the research and the policy because you have a wealth of data already captured by the electronic health records, and you need to know how to use them for research. You can use that for predictive public health, so you no longer have to do these surveys and collect your data. There is already data, and then you have to ask yourself, what this data can tell me about the population. Again, the starting point of thinking here is the existing data. That has not been emphasized a lot in our public health kind of conceptualization of what this field is about. Another big part also that public health specialists should play a role is how to monitor, so create some methodologies and studies on how we monitor the impact of the digitalization of healthcare systems on the equity. Again, because we know that digital literacy is a huge problem at the moment. Not everybody is so comfortable. I'm a millennial, so I'm in a generation who have worked analogically in analog and now digital, but I can see that a lot of people can struggle a little bit with their digital skills. Now, imagine if we digitize every single initial door for our healthcare system, assuming that this is going to democratize access, but in reality, it might actually have an unintended consequence of increasing inequality because of all of this digital divide that we have at the moment. So, this is the new roles as I see in public health professionals doing, and I'm involved with a couple of EU projects who are actually looking at how public health professionals should work, or type of skills they should have to actually work efficiently in expanded team compositions that include like informaticians, AI specialists, and software engineers. So we should not, there is no chance that we have to stay siloed where it's like, this is just the IT system or the software that's in the hospital, and we as public health, we create our own data, and we create our own surveys, and we create our own studies out of it. That type of dichotomy that no longer should exist. So public health professionals have to learn how to work with informaticians when they even craft a software to be used to capture any health data, how they allow this data to be standardized so they can be used for secondary use. So as I said, they can play a role into the data collection up till interpretation. They can also play a role into understanding or evaluating how the whole digital transformation or the use of AI as well impacting all public health competencies, if that makes sense. So, and then the biggest elephant in the room is that as we digitize our healthcare systems, we generate a lot of data, but then it's and also with AI, it puts us in a place where we have a lot of ethical dilemmas that we have at the moment. So if you use, for example, any AI tools to predict an outcome of a patient, or to suggest the next diagnostic solution that a clinician should do, or to give directly a diagnosis, who is going to be reliable on it? So the whole digital transformation brings us a lot of dilemma or ethical dilemmas and trust dilemmas and governance issue that we need to sort out before, so we don't lose the trust of patients. And I'm based in the Netherlands, and whoever based in the Netherlands, if you know, 2 months ago there has been a leak for almost every single results or all of the database that carry the screening results of HPV national campaign here in the Netherlands. As you know, if you are 35 plus, you are requested to be part of this screening program, national screening program, and the database for this has been leaked almost like 2 years ago, and that emphasizes how, for example, cybersecurity becomes a big problem, and how if we public health professionals have not been integral into conceptualizing the data governance concepts and operationalizing them, then you lose the trust of the citizen, and that will be a bit of a disaster. So two things here stand up for us as public health professionals trying to navigate this maze of technology and how technology is adopted by healthcare system. We need to first understand how the technology might lead to even further fragmentation of the system, or if we could tackle interoperability quite well, then that will decrease. And the second thing is the workforce gap. Every clinician now have to be able to document care in EMRs. I remember in a lot of hospitals when I go, some nurses have never even seen an EMR because it was not around when they have graduated nursing school, and also clinicians. So we are actually at the moment in a lot of hospitals dealing with multiple generations that have different literacy or feasibility of using technology, and that has to be taken into account when we look at digital transformation of healthcare. And the best people to actually study these type of impacts are public health people. So just to conclude, I think the digital transformation of healthcare as we go through it now, and especially AI as well, and as we prove what are the proof concepts for AI use cases in our healthcare system, we are going to redefine what public health actually is mean. We're going to redefine how we generate evidence-based actions on a population or an individual level. And then us as professionals has to be evolving. We have to adopt and maybe upskill at some point to understand how we can perform still the same public health capacities that have been trained of epidemiology, statistics, and so forth, but how we are going to practice this is going to look very differently in the digital age. So by this, I conclude my my talk, and I hope that this a little bit inspired you and give you some thoughts to think about as you move to your next thing.
Thanks so much, Mariam. That was amazing. Now for our final speaker of today, we have Feresteh Kazemipour. She is a second-year EPH student. She also did Sheffield Maastricht and a medical doctor with an MBA. She has experience leading digital health projects and helping health professionals bring their ideas to life. Feresteh, please take it away.
Hi, thank you, Brenna. Let me share my screen. Well, I really enjoyed the previous talks, and I really understand Mariam's interest and passion to digital transformation. I am also trying to do something almost the same, inspiring you and showing how it's important, how much important it is to know about digital technologies in public health, which I think is neglected. And I hope you're not too tired right now. It's the last talk. I also go give a short introduction about myself. I studied medicine, and in last semesters, just before internship, I realized that I don't like practice as my future. So, and in that time, I started learning about digital health. And what was interesting for me was that I realized that a digital solution that is well designed and distributed, which a solution that solves a real problem, can save more people than a doctor can do during their whole life. So it was a very interesting point for me to realize that, okay, it can be even more health saving. let's see what digital public health means. So digital public health is a really recent term. It's first used in 2019. And according to Public Health England, it refers to the use of digital technologies and data to improve population health and well-being. But digital health is a term that is older. In 20th century, we had electronic health. It was a trend. And after mobile phones became common, we had m-health. And in 20s, digital health was first used. We can say digital health means using digital technologies in healthcare, and digital public health uses digital technologies as tools to help us achieve public health goals. And I'm going to explain 6 of these technologies. First is Internet of Things. Internet of Things is a good example of it is smartwatches. Smartwatches collect information about our sleep, activity, and other health indicators and share them with our phones. So what are its use cases in healthcare? It can be used for remote patient monitoring. For example, a device can track a patient's vital signs remotely, and if there is any unusual change, it alerts caregivers, and it defines unusual changes with AI. Most of these technologies are used together in combination. The same thing can happen in hospital, and in that case, we call that smart hospital equipment. Monitors and sensors that are connected, and with AI, they can help caregivers to make decisions and provide care. It can be used for medication management. For instance, InPen is an FDA-approved insulin pen for people with diabetes. It's smart. It's connected to a mobile app, and it records when patients use their insulin, and also based on their activity and their food intake, it calculates their dose, the next dose, and also it calculates their food intake, carbohydrate intake, and it's a digital logbook as well for the patient. It helps them to control their HbA1c and their glucose level. The same company, Medtronic, also has a system that uses a body sensor to continuously measure blood glucose, and it's connected to a device and an automatic injector. So in that device, that's not only informing patient about the next dose, it automatically, based on measuring the blood glucose, changes insulin level for next doses and injects it automatically. The next technology is 3D printing, and it is, in simplest words, is a method of creating a physical object by adding material layer by layer at a time. It can be used in medical education for practicing rare surgeries. For example, some years ago, when a 2-year-old boy in America had a rare brain tumor, surgeons at Stanford University created a 3D print of his skull based on his imaging, and also used VR glasses, the technology we are talking about later, to practice several times before performing the real surgery. It reduces the risk of negative outcomes in surgeries. Another area is tissue and organ creation. Printing a full organ is still far from reality, while it is the final goal. But tissue grafts like skin and bone have already been successfully printed and have saved many lives. I think it was 2017, the woman was saved in Utrecht by surgeons from University of Utrecht with a skull bone material 3D printed, just like the one that is on the slide. It's also used in several other countries, and it's common now. 3D printing is also used to make prosthetics. And another interesting field I want to just mention is food technology. We know the environmental effects of livestock industry. So there are startups that are working on alternatives of meat, some with vegetarian or plant-based protein, some with cells that are created from meat, real meat, and is growing into a meat-shaped thing. It's based on biotechnology. And in both technologies, they use 3D printing. Some of these meats are already in use and commercialized in Netherlands, US, UK. An example here is Project Daniel. In 2013, the Not Impossible Institute took 3D printers to Sudan, where the chaos of war had left many people with amputated limbs. And what they did was that they took the equipment and trained and empowered local people so they could print patient-specific prosthetic limbs for people there, even after the institute people left. These 3D printed prosthetics cost around $100 compared to traditional ones that cost $10,000 to $15,000. And next we have extended reality. So we know virtual reality by those big glasses that take us into a new world. Augmented reality, on the other hand, adds digital content to the real world, and Pokemon Go is a good example here. And mixed reality is any combination of AR and VR. Extended reality is an umbrella term for technologies that use AR, VR, and MR. Use cases are patient education. For example, a doctor can explain a condition and treatment plan by virtually taking the patient inside their own bodies, showing them what's wrong and how they're going to fix it. Another important area is mental health, especially for patients with anxiety, phobias, and PTSD. For instance, people who have experienced a fatal accident and are afraid of driving can benefit from exposure therapy using VR to gradually overcome their fear. Pain management is another area. Studies show that for patients undergoing a painful procedure, using VR to take them to a peaceful virtual environment helps reduce their perception of pain. And also, as mentioned, just like 3D printing, VR can also be used, XR generally can also be used for medical training and surgical planning. Artificial intelligence. Here I use artificial intelligence for big data, AI, or machine learning. Generally, and it's somehow covered in previous talks. I just go shortly over them. So in surveillance and population health, it was already mentioned by Mariam. AI can help analyze data of several sensors or data gathered from environment or patients to predict outbreaks or even in real time guiding decision makers. For example, predicting that when I forgot the word, lockdown is needed for controlling the pandemic. Another important area is drug and vaccine discovery. We know that one of the COVID-19 vaccines were designed by AI. So AI can be used to define which part of the a cancer cell or a virus is a good target for the medication, then it can help to design the molecule that should be in the medication. And also it helps in clinical trials in deciding who should be recruited and also managing the data afterwards. Another area is clinical care and diagnosis. So in medical imaging, there is a lot of talk about it. In radiology, pathology, and also in dermatology for diagnosing skin problems and skin lesions. AI has been used for a long time, and it's an area that there's a debate if it can take doctors' place or not. But currently, it's not the case. It's how it helps to diagnose problems. It can also recommend treatments. For example, in cancer, we have very complicated regimens, chemotherapy regimens, and AI can help to decide what regimen the patient should take. Also, what another aspect that is important in communication in public health is communication support. It can help us treat people's with whom we have language barrier. It can be used as a real-time translator. Here is one of my favorite startups. It's an Indian-based startup named Niramai. It's founded several years ago. I think it was definitely before COVID. And what it does is that it's a breast cancer screening device. It is a small, just the camera that you're seeing, and it's portable and it's privacy sensitive. It doesn't need the process that patients go through in mammography, and it is affordable. So it helps take the device and it makes the screening available for patients living in rural areas. And how it works is that it takes thermal scans, and AI finds out colors that we can't see with our eyes. So it can find the areas that because of blood vessels or any risky tissue, it can be a sign of cancer. Also, there are other research that show AI can predict breast cancer 4 years earlier, and it's really, really impressive. Another area, which is my favorite one, is resource optimization, and it's mainly used in hospitals. So AI can be used for patient triage, like how we use ChatGPT for asking our symptoms. It can be modified and enhanced to be able to decide triage people who should be seen first, who is not in an emergency mode and can go to a GP. It also can be used for hospital admission or readmission prediction. So when a patient comes, gets treatment, and is discharged, based on their data, their recovery time, and data that is probably gathered by IoT devices and sensors, can predict patients' readmission time. It can also predict patient load in times like COVID time. It can help with patient flow management in surgeries, for example. It can shorten the time that patient is in hospital. Qventus is a startup that is working on this. So there are a lot of times that patient is kept in hospital unnecessarily. Also, there are a lot of surgery cancellations. It manages staff schedule and also surgery planning. And another thing is remote monitoring, which we already talked about in previous sections. Here we have blockchain, and it's one to the last. Blockchains sometimes ago were a very promising trend in health, but now it's not that much. It's just like if you remember metaverse, it came, it was a there, it was shortly there, and then now no one talks about that. But there is a specific area that blockchain can help, and that's data sharing, especially for drug discovery and medication designs in clinical trials and health research. It allows patients to share their data, or health organizations to share their data with pharmaceutical companies in an anonymous way. I know there is a lot of talk about privacy and how it will happen and ethics behind that. All of them are there, and it's not. I don't think it's going to happen soon, but it's a trend, and it can be helpful there. And last one is virtual and home care. So somehow we can say that it's not a trend, it's not something new. It can be telemedicine, teleconsultation, what we already have, and which increased a lot in during COVID. But an important aspect about it is that we have some problems. We have aging population, a rise in chronic diseases, and also healthcare costs are growing everywhere. So virtual care and virtual hospital is a trend by itself, and it's using all of the technologies mentioned, IoT, AI, telemedicine, to help reduce the burden from hospitals. Because so many of the diseases can be treated at home, and there is no need for going to a hospital. And in systems like US, that health costs are a lot and are dramatically high, they are deciding to making hospitals smaller and using them only for surgeries, only for the things that should be done, and shorten the time that patients spend in the hospital, helping them to spend their recovery time in their home. It is more convenient for patients, and also it helps healthcare costs. So we already talked about telemedicine, and we already talked about remote monitoring, and home care is just it can be analog, not a digital thing, like a patient, healthcare doctor or a nurse can go to take samples, to take tests, or treat the patient, or actually examine the patient. Or it can be also, again, digital, like kits that can be used by themselves for uh, taking a sample, like a urine sample or a saliva sample for diagnosing diseases. Uh, I'm so happy that Mariam already mentioned the need of digital literacy. I think it's a very essential skill, and I think it's not emphasized enough in public health and public health education. Uh, Healthcare adopts technology slowly, much slower than other technologies, but public health is even slower. And I know that some of you might not be very digital savvy, savvy, but and I know that there is a risk with technology and new technology solutions, just like any other interventions, just like a new drug, new vaccine, but it shouldn't stop us from seeing its benefits. And it will be there. That's why it's called digital transformation. It's called uh, a wave. It's the fourth wave. and it will happen, but our public health system is not ready for that. And we don't need to be a tech expert, but we should be tech aware enough to know when to use it and how to use it to be able to create policies about that and make regulations, help hospitals manage the technology, as mentioned by Mariam. There are roles that are called digital transformation officer in hospitals, I think mostly in US. And these people are mainly digital or engineer or managers, managerial background people. But when you think with all the things that's in public health we learn and we know about population health, I think we should be ready to take those roles. Thank you. And these are the connection links, and I'm here for questions.
All right, thanks so much, Feresteh. That now brings us to the end of our speaker portion. We are over time. So as I mentioned a little before, if people need to leave, then that's perfectly fine. Please drop your questions in the chat, and we will see if there's a way to have those questions to be compiled, and we can potentially work with our speakers to circulate some responses. So if people have to go, it's okay. For our speakers, are you okay to stay around for a few minutes to answer maybe one question each? Okay. All right, so we'll get into that then. We did have a few questions earlier in the chat, so I'll start with Vianney. One of our questions from the chat was, how is the data from the projects utilized in decision making, and how do you use this data when communicating with stakeholders?
Okay, thank you for this question. I have a concrete example, a local one. So it was during the COVID-19 pandemics, we were producing real-time indicators about what was going on within the hospital. It was about the hospital burden of the COVID-19. And from this data, we were also building predictive model using AI to predict the next wave when it was coming. And these data were used twice a week during the crisis unit meeting with the director of the hospital and the representative of the medical teams to decide whether we need to reorganize the hospital in real time. So this is a great example of how this data can be used to make decision. It's a really secondary use of data. And the same way in the Orchidea project, the idea is that the data are not used by the hospital themselves. They are sent to Santé Publique France, which is the French Center for Disease Control, the equivalent. And Santé Publique France, from this data, can make decisions such as lockdown or stop the lockdown, which has a really significant impact over the population, good or bad. Even locking down people is not that good. So we need to decide when we need to stop this and optimize that. So we hope we will be able to do that. And other example is really the Darwin EU network. So it's not directly the Bordeaux University Hospital that will communicate the results, but Darwin will communicate with EMA. And from these results that are built upon multiple institutions on the Rio Grande territory, EMA can make decision of identifying potential adverse event, changing the way we should prescribe some kind of medication, and send this kind of decision to the national level decision making for medication surveillance. And there are already real impact about that. And the last point, sorry, I talk so much. I'm sorry for that. But the last point is that when you communicate this result, you have to be really careful. You need to ensure that the process of the way you've built the result, the way you've built evidence is fully transparent. You can explain every step, even the step of transforming the data, extracting information from free text. You need to rely on the people that have built the result to be able to explain, because there are potential decisions with impact over the population. And we need to get in maturity at the European level on that. This is something really important because you can predict any kind of results because you have a lot of data. So you have to be really careful on that. And this is for public health for sure.
Thanks so much. All right. For Mariam, one of the questions we had from the chat as well was, how do you handle cross-border issues in sharing data, such as language or context barriers? So, for example, France does not collect demographic information on race. So, how do you handle these sort of sharing issues?
Yeah, this is really a very good question, and I tried to type an answer in the chat, but just shortly, at the moment, there is a very limited use cases for how data is moving cross-border between countries. And at the moment, most of this data is mobilized through the My Health at EU. It's a kind of an infrastructure that connect something called national contact points. So every member state in the EU countries have a national contact point in which the data of a patient move from the hospital to this national contact point, and this national contact point share the data with the other national point, and usually through a terminology modular and also through a language change. But of course, since European health data space now is going to to basically give patients their own subset of data, and then they will have to take it and go to another provider in any other member state and kind of share it with them. Then of course you would assume that there will be in the EHDS infrastructure, when this is agreed to how it's going to look like, because at the moment there is not enough clarity about it, then there will have to have a lot of language translation mechanisms in between. Now, the context is the biggest problem because, again, data is generated in a context, and no matter how you standardize the data, so you use a SNOMED terminology and whatever, if the other pharmacies, if the other countries does not use the same medical terminology, then it's going to be a problem. So this whole interoperability, kind of standardizing data and understanding the context in which this data is produced is actually a big barrier at the moment that a lot of the experts is trying to understand how we're going to tackle it. But again, the cross-border data sharing at the moment is really a little bit not a very big use cases, and it's mostly around rare disease use, because of course there is only centralized rare disease specialist centers in Europe in which patients have to go to. For example, I use a rare disease center in France, but all my data is generated here in the Netherlands. So it's a bit of a fuss for me to take all my data and allow it to be shared there at the moment. But hopefully within the coming 4 or 5 years, as we move in the implementation of the EHDS, this can change a little bit. Now, whether it continue to be mediated, so that's data transfer completely mediated through the hospitals or the providers versus mediated through the patient themselves, because they have a patient record, but that's very different than the electronic health record that's maintained on the provider side. This still needs to be decided, and every country have its own methodology and strategy here. So yeah, we're gonna have a very exciting 4 years coming then for the HDS implementation.
All right, thanks so much. And finally, for Feresteh, as you discussed, sophisticated technology like VR and AR is transforming the avenues of patient support and rehabilitation. But would you say a limited digital literacy and trust on technology among patients and even doctors impedes the efforts in digital transformation, especially in LMIC countries? Sorry, lower middle income countries.
So the question is if not trusting the technology from patient side or caregiver sides affects digital adoption in lower income countries. Let me think. I think it is a problem, but technology adoption has always been a problem. It's a problem everywhere. It has a curve when some people who are trusting technology start to adapt it. And there are the next wave. There are people who, by seeing that some people are using that, trying to slowly trust the technology. It goes with a new phone, it goes with any technology, and it's about healthcare providers, it's about patients or consumers in other technologies. So it is always a problem, but I think it depends how they see that the technology is going to solve their problems. And digital transformation should be started from inside of the hospital or inside of the organization. I mean, it should address the problem of all the stakeholders. We didn't talk about today. We didn't talk about founding a startup, but it has steps that help you find out what problems are real problems, what are just good to have, or there is no need for them. And also, I think another important problem in every country is that policies are slower than the technology. So technology comes and then there is no regulation about that. I think that's another important issue in lower income countries.
Well, thanks so much to all our speakers. Haley, would you like to close us out?
Yeah, thank you all for coming, both to our speakers and to our participants. I know this went a little bit over time, so I appreciate everyone staying. But we really hope that you all learned a lot about digital health. Just once again, thank you all for volunteering your time and spending the night with us to learn more about public health and digital health. So thank you all and enjoy your evening.